Hello friends, good evening. I hope everyone is fine. In this video we will talk about the quantitative thrombocytopenia. In order to define the thrombocytopenia, first we need to know what is the normal level of the platelets in the body. The normal level of the platelets in the body is from 150,000 to 450,000 per cubic milliliter. Now, the definition of the thrombocytopenia is whenever the count of the platelets or the number of the platelets in the body falls less than 150,000 per cubic milliliter, we call it thrombocytopenia. Now, once we have defined the thrombocytopenia, let's see what are the causes of the thrombocytopenia. These are mainly can be divided into two group of the causes. One are the conditions where there is decreased production of the platelets, and one in which there is increased destruction of the platelets. We all know that the platelets are produced in the bone marrow. The causes of the platelets deficiency in the body can be, it can be radiation exposure, it can be drugs and the chemicals, acute leukemia, myelopathy in which the bone marrow is replaced by the tumor, fibrous tissue or granulomas. It can be aplastic anemia which results from the cytotoxic drugs, benzene and radiations, and also the cytotoxic T cells. Splenic sequestration also causes thrombocytopenia, where we see that the platelets, they are sort of removed from the circulation by the spleen. It can also be caused by the multiple blood transfusion, where we see that there is dilutional effect of the blood transfusion on the count of the platelets. Disseminated intravascular coagulation is another very important reason for the thrombocytopenia, because it uses up or consumes the platelets. And there are certain systemic conditions which can also cause the problem of the thrombocytopenia, like AIDS and SLE. They are very. After the causes of the thrombocytopenia, those patients who are suffering from the thrombocytopenia, they can come to the hospital or the doctor with the certain clinical features. The majority of these clinical features, these can be the petechial hemorrhages on the skin. These can be the intracranial bleed, and it can also be the oozing of the blood from the mucous membrane. Now, most of these patients, when they come to the hospital, then the majority of these patients will undergo a very particular workup. One is knowing about the bleeding time. In the old days, especially, it was used to be performed by the doctors. We used to prick on the finger of the patient, and we used to switch on the timer. Then we used, after every 30 seconds, we used to wipe off the blood from the finger, which we did the pricking. And the moment the bleeding stops from the finger prick, we used to stop the timer, and we used to calculate how much was the bleeding time. That's a rough idea about the thrombocytopenia. But nowadays it is not performed very oftenly. Now, bone marrow aspiration is also done. When we do the bone marrow aspiration, we take out a part of the bone marrow and we analyze it under the microscope. Megakaryocytes are the precursors of the platelets, and in those conditions where there is increased destruction of the platelets in the circulation, there will be higher concentration of the megakaryocytes in the bone marrow. But those conditions where there is reduced production of the platelets in the bone marrow, there will be decreased count of the megakaryocytes in the bone marrow. In the context of the quantitative thrombocytopenia, there are two very important conditions which we should also talk about. These are the thrombotic thrombocytopenic purpura and idiopathic or immune thrombocytopenic purpura. Talking about the thrombotic thrombocytopenic purpura, what happens in this condition, that there is a deficiency of the very particular enzyme which we call the von Willebrand protease factor, or it is also very famously known as ADAMTS13. Now, because of its deficiency, there is increased formation of the ultra weight multimer of the von Willebrand factor. When these are present in the higher concentration in the blood, there will be accumulation of the platelets. Along with these, there will be aggregation or micro aggregation of the platelets in the small blood vessels. Now these platelets, they plug together, they also do not let the RBC pass through it properly. They squeeze it and they change the morphology of the RBCs and convert them into the helmet RBCs and schistocytes. Not only this, but this microaggregation also makes a lot of problem for the microvasculature of the kidney, and it also causes the transient neurological deficits and also the fever. Now, the thrombotic thrombocytopenic purpura, it is equivalent of the hemolytic uremic syndrome. In hemolytic uremic syndrome, this particularly happens with the microvasculature of the renal or the kidney system, where this happens in response to the Shiga toxin in cases of the E. coli infection or dysentery as a result of the Shiga dysentery. And in those cases where there is infection of the E. coli, it is 157H7 infection. In the response of that infection, we have the development of the hemolytic uremic syndrome. While the other entity which is very important is known as the ITP or idiopathic thrombocytopenic purpura. The other name of it is the, we also call it the immune or autoimmune thrombocytopenic purpura. What happens in this case that it happens in children as a transient phenomena in reaction to the viral infection or the immunization, but in case of the adults, it's a chronic process which is going on in the patient. So it's a three-step procedure. In the step 1, there is formation of the antibodies against the platelets. In the step 2, there will be attachment of these antibodies with the platelets, and these platelets will be coated and then will be damaged by these antibodies, which you can also call the autoantibodies. And in the third or the final step, these macrophages from the spleen, they engulf these autobody coated platelets and destroy them and remove them from the circulation. Now, when the most important features of the idiopathic thrombocytopenic purpura, these are the low platelets, increased megakaryocytes, and there will be absence of the palpable splenomegaly. So friends, that's all about the quantitative thrombocytopenia. And at the end of the video, I request you to please subscribe the channel, like the video, share the video, and thank you so much for watching the video.